Hi, I'm Carlos Fernandez de Larrea. I am a hematologist working in Hospital Clínic in Barcelona, Spain. And I'm so honored to present a summary of our work presented at the Presidential Symposium of the European Hematology Association in Vienna in 2022. We presented the results of efficacy and safety of our academic BCMA CAR with a fractionated dose and a booster dose for patients with relapsed refractory myeloma. Here you can see my conflict of interest. We have an impressive improvement of the overall survival of patients in the last years. However, we know that many patients will relapse and progress, and some are going to be refractory to the treatment that we have until now. At that moment, we don't have many options for the treatment, and the prognosis was a little bit short in terms of survival. For that, one of the main hope when we are dealing with this situation for this population of patients is immunotherapy, and particularly CAR T cells. We have 2 CAR T cells approved in Europe and US for the treatment of refractory relapsed multiple myeloma, ide-cel and cilta-cel. But today, we are going to talk about ARI0002h. That is our CAR T, is a CAR T directed against BCMA, this protein on the surface of the plasma cell, similarly to ide-cel or cilta-cel, that have been humanized and is quite similar in the other parts to the commercial ones. In this trial, our idea was to explore the safety for the patients, particularly the inflammatory response and neurological toxicity after the CAR T infusion, as well the efficacy, the response rate, the percentage of patients that showed any degree of response. We developed this clinical trial in 5 institutions in Spain. In Barcelona, we produce the virus to infect the cells and to produce the CAR T cells, and also we coordinate all the clinical trial. We produce the CAR T cells in 2 places, in Pamplona and in Barcelona, and we treated in 5 hospitals, in these 2 that I have mentioned before, and in Sevilla, Murcia, and Salamanca. Mainly the patient has to have a certain amount of protein in urine or blood, and to have received at least 2 previous lines of treatment, including one of the drugs of the main 3 families of drugs that we are using right now for multiple myeloma. As an important point in this trial, we decided to fractionate the first dose in 3 bags, that it was 3 million of these cells per kilogram of the patient after a chemotherapy in order to adapt the body for the cells, and after a second infusion after 4 months of another 3 million in only 1 bag for patients who have some degree of response and no limiting toxicity. This is the characteristic of the 30 patients that we have treated until now. We are now recruiting a second cohort of 30 patients, and the majority of patients had relapsed after autologous stem cell transplantation. They were all exposed to the 3 families of drugs. 2/3 were refractory to the 3 families of drugs, and with a median previous line of treatment of 4. They have received, at least in general, a median of 4 previous line of treatment. And this is the main result, the efficacy. All the patients showed at least a partial response. All patients responded to the treatment. And 63 responded with a complete remission, and almost all achieving a very good partial response. That is a very good news for the in terms of efficacy. And that was associated with a negative minimal residual disease in the bone marrow by flow cytometry up to 92% after 3 months of the treatment. When we evaluate the persistence of this response, we have seen that after 1.5 years, more than 50% of the patients are still alive without progression. And in terms of survival, 3/4 of the patients are alive after 1.5 years after this treatment, even they were treated with a lot of therapies before. We can see here the activity also of this plasmacytoma, the tumors arising from the bone or coming from the blood. That is impressive, as you can see in this PET-CT of a patient. That was our first patient treated. And that was also in patient with plasmacytoma, not only coming from bone, but also with hematogenous, with blood dissemination, that it was this patient that is still in response, in complete remission, more than 20 months later. Safety was quite safe. Almost all patients showed some toxicity, but in terms of inflammation or cytokine release syndrome, it was always mild, and there was no any sign of or neurological toxicity. That is quite also safe in terms of use that for patients. And we use also a second infusion in 24 of the 28 patients that were without progression after 4 months. And even in this population, 6 of these 24 patients, they show some degree of response. They improve the response that they have achieved previously with the first dose. In conclusion, this CAR ARI0002h is the production is fast. We can produce in around 10 days and feasible for all patients. The response that we have obtained are deep and sustaining during the time over the 1.5 years that we have evaluated the patient, and with low grade toxicity. And we think that this CAR, that is an academic humanized CAR T against BCMA, is clearly a promising therapy for our patient with relapsed refractory multiple myeloma. I would like to thank all our patients and their families in the 5 Spanish hospitals that participated in the trial, and to all our team that could achieve this goal to treat patients into a public health system with an academic alternative with immunotherapy for our patients with multiple myeloma. Thank you so much.